First of all, I would like to thank you for inviting me, and I will talk about the prognostic factors in diffuse large B-cell lymphoma. Uh, as you know, this is just one slide for the background. Diffuse large B-cell lymphoma is the most common type of non-Hodgkin's lymphoma. It's about of 30 to 40% of new diagnosed in non-Hodgkin lymphomas. It is a very heterogeneous disease and presents a cure rate about 80% for the limited disease and about 50% of advanced disease using the first line therapy. The IPI score and age-adjusted IPI remains as a benchmark for diffuse large B-cell lymphoma. And you have three groups of prognostic factors in elderly patients and young patients with low risk, young patients with high risk. But the standard therapy for most of patients is the rituximab and SHOP or SHOP-like every 14 days or 21 days. It's the classic paper published 20 years ago by Chip and collaborators, and is very useful until now. And we use a very simple and cheap data like age, LEDH, performance status, an arbor stage, and extranodal involvement. And this model stratified the diffuse large B-cell lymphoma in four groups of risk: low, low intermediate, high intermediate, and high risk. Some years before, the Canadian group published the RIPI, and the low and low intermediate became the very good group, and then a group, and is still poor risk patients, also for survival or for progression-free survival. Another factors can influence the prognosis of this kind of disease. One is the bulk disease that remains also in the rituximab period as a isolated poor factor for prognosis. And you can see here in D, you can see the patients with bulk disease more than 10 centimeters still patients with poor prognosis. Another data in prognosis is the bone marrow infiltration, and the infiltration with a large cell. And it's just one paper, we have others, but when you can see a poor prognosis for patients with bone marrow involvement with large B cell, similar to the lymph node. Here we arrive for the biology, and in almost 15 years ago, we have a first paper using the Germinal Center diffuse B-cell lymphoma, showing a better prognosis compared to the others like ABC and primary mediastinal B-cell lymphoma, and this is the original paper, and we can see here the Germinal Center B-cell lymphoma and ABC B-cell ABC, and one third type 3, and this paper showed a better prognosis for Germinal Center B-cell diffuse large B-cell lymphoma compared to the others, type 3 and ABC. It was confirmed 10 years after, when you can see here the overall survival and progression-free survival for whole group and the better prognosis for germinal center compared to ABC, and in terms of overall survival or progression-free survival, and germinal center compared to no germinal center, included ABC and classified or type 3 and, lymphoma. And here it's more practical and probably cheaper using the immunohistochemistry when you can stratify the germinal center B type with non-germinal center B type, and still the better prognosis for the germinal center B type using the CD10 and MOON and the BCL6. Important prognostic factors are the biomarkers. And the first one was the BCL6, when you can see the negative BCL6 expression protein is better compared to the positive or lower half RNA expression, better for upper half the RNA expression. It's a very important, and the next talk, the Dr. Windham will talk about the double hit, but the impact of MYC rearrangement and double hit have an important prognosis in diffuse large B-cell lymphoma. And all of these abnormalities like MYC translocation, BCL2 translocation, BCL2 protein high, and MYC protein high are a poor independent prognosis in terms of event-free survival and overall survival in patients treated with classical R-CHOP. And MYC overexpression, BCL2 overexpression, BCL6 overexpression, and all of them present a bad prognosis. It's a Kaplan-Meier curve using the R-CHOP, showing the presence of MYC or BCL2 has a worse prognosis compared to the patients without abnormalities, but the double hit presents a worst prognosis in this group of patients. It's very important, the double hit, the MYC BCL2 co-expression, and you can see the co-expression is more frequent in patients presented ABC type compared to germinal center type. Here is BCL2, MYC, and both. And you can see here BCL2, MYC, both, or without the double hit. It's always more frequent in ABC type, and probably it's the cause of the worst prognosis in ABC type compared to germinal center type. Here you can see for all cases the germinal center ABC in terms of overall survival, progression-free survival. Here no MYC or BCL2 in both groups, and no differences you can observe in terms of overall and progression-free. And double hit, MYC, BCL2 only, when you can see for both germinal center and ABC, the prognosis very similar. The MYC status in concert with BCL2 and BCL6 present always poor prognosis, and you can see here the MYC break negative, break positive for event-free survival and overall survival, and we have a break BCL2 negative and positive. It's very similar for event-free survival and overall survival. But when we have 0 or 1, it's very similar, or double or triple hit poor prognosis in terms of event-free survival and overall survival. It's a very important study using a dose-adjusted epoch rituximab, when you can see the germinal center and non-germinal center for whole group. But when you stratify using the Ki-67 low or high, you can see also in non-germinal center, when Ki-67 is low, you have a better prognosis in this group of patients. What about upfront therapy for high-risk patients? Only 2 or 3 slides showing no difference between the R-CHOP 14 compared to R-CHOP 21. It's a very practical, has a very important practical factor. Another trial using a high-dose sequential with the peripheral blood stem cell collection and transplant compared to CHOEP 14 using etoposide, when you can see no differences or better evolutions for conventional chemotherapy or immune chemotherapy compared to high-dose sequential in this group of patients. And now we have a concept to do not use the autologous stem cell transplantation first line in diffuse large B-cell lymphoma. And then the prognosis, it's just one slide. The prognosis for patients indicates to bone marrow transplant, when you can see the factors involved to the prognosis of autologous stem cell transplant. The relapse before 1 year, it is very important. The early relapse is very bad prognosis for transplant. And then the transplant in progressive disease, it's very bad prognosis. And IPI still remain in the relapse or progression as a factor. And then the LDH, very simple. And so for transplant, the factors using in upfront and then the time of relapse and progressive disease is still the most important factors, prognostic factors. Thank you.
So I thought that was a really wonderful overview. I just wanted to highlight your last few slides, and that is that, you know, when you look at transplant upfront in large cell, even though there was no difference between CHOEP and mega CHOEP, the mega CHOEP was actually lower. And I think that, you know, this really highlights why, and I know I keep on saying this, but I say it because there are so many people out there constantly saying transplant, transplant, transplant. But when it is actually looked at in a rigorous way, there is very little evidence that it really adds. And you would think that if it was going to add up front, it would at least not show a worse outcome. And, you know, and there have been multiple upfront studies using randomized studies using consolidative transplant, and they have routinely shown this same thing, that upfront transplant doesn't help. And even in the salvage setting, the subset of the subset of the subset that you ultimately take to transplant ends up with a long-term cure rate, probably if you look at the entire denominator of people who relapse, of around 10%. So it's very, very low.
I got a couple quick questions. You know, first, actually, just a little bit for you, Wyndham, because it was your paper. Why do you use 60% for Ki-67 in that versus 50 versus, I mean, how'd you pick 60 there? Was it just how the numbers came out or?
Yeah, I mean, that was a exploratory
Okay.
finding, but, it very much goes along with what we heard, where if you look at MIC IHC, it is that if you look at ABC, if the MIC IHC is low, the outcome was good, and MIC actually is a indirect a marker of how rapidly the tumors are actually turning over. So the result we showed with EPOC was very similar in that if you have a slowly proliferative tumor, relatively speaking, even if it's ABC, your outcome is very, very, very good.
And the second one is the bone marrow is kind of interesting because the bone marrow niche on how poor those patients could, and I don't know if Dr. Hoyer could help on this one too, but the question is, why is the bone marrow, such a negative prognostic? Is it because the bone marrow is relatively hypoxic and that the hypoxia often leaves these cells into a more quiescent or, kind of stem cell-ish, and, that we've seen that state. Do we know why the bone marrow is such a negative prognosis for lymphoma?
Well, what I can say is that it became much more obvious that that it had a worse outcome, because in the older studies they didn't distinguish those patients that had large cell within the marrow versus small cell. If you look at patients that have small cell within the marrow, essentially comparable to a transformed follicular, there was no adverse effect. And those are not de novo large cells. But if you look at just those patients that have large cell, obviously the outcome is very, very poor. I don't know. I mean, in general, ABC tends to be a more extranodal disease. They have higher NF-kappa B, and so some of that may be driving this. They have a higher rate of going to the CNS as well. But quite honestly, it's not really been looked at from a biological point of view very carefully.
How the cells may be protecting themselves in the bone marrow niche,
Yeah.
which again, we know with leukemia, that's one of the key things, and maybe even with certain drugs that actually get the cells out of the bone marrow niche,
Right.
there may be, that microenvironment may be protective. So I just
Maybe.
didn't know if we knew it at all for DLBCL.
Not really.
Well, there's two things. I think biologically, large cell lymphoma in the bone marrow probably is something related to chemo resistance. And of course, this is speculation. Yesterday, somebody asked me how to deal with the diarrhea with the Revlimid or ibrutinib-induced diarrhea. I promised you I will come back with what I was going to do. So I used cholesterol. This is all available in the U.S. Cholesterol is very effective in Revlimid-induced diarrhea and ibrutinib-induced diarrhea, almost without a miss. Thank you.
I have a comment for bone marrow. It's very interesting because during the relapsing patients, the bone marrow is not a factor for good evolution, for better or worse evolution. Only at diagnosis. It's a very interesting observation.
That's probably true, but one of the difficulties there is that most relapsing patients have such a poorer outcome that it may be difficult to, tell that.
Yeah.
I mean, they really all do very poorly. Only a very small number do okay.
I think in the last ASH meeting, it showed that the addition of bortezomib to R-CHOP was not beneficial for ABC type. Is that right? Is there any drug that we should consider for first-line treatment for ABC type?
Let me have Mark answer that.
Wyndham, you're much better at answering it than I.
Well, I would say that if I came down with ABC type today, I personally would want to add ibrutinib at least to my therapy, and I might even consider adding lenalidomide as well. But that is without the randomized studies. But quite honestly, if you've got large cell, you really have one chance of being cured. So I would rather, take those drugs, and I'll wait for the randomized studies later.
They echoed that point. We're in the U.S. 60% of the people with R-CHOP, large cell lymphoma, went into a long-term remission. 40% die, and from the relapse and primary resistance. There's a good data to see that adding Revlimid make the R-CHOP look better. And there's another trial saying that adding ibrutinib make the R-CHOP look better. So R-CHOP is the baseline framework, and adding Rituxan and adding Revlimid and ibrutinib together, absolutely the way I want to go. But I may go even step further, is to add it to EPOC. Why not only add it to R-CHOP?
Well, I try not to push EPOC until we have a randomized study, because I'm harping on the fact that we need a randomized study. Having said that, Pharmacyclics and we are doing a study of EPOC-R plus I and L in relapse ABC, and that study is ongoing.
I have one more question regarding your view on transplant. Would you not consider transplant for transformed follicular lymphoma?
Now, that's a good question. I think that that's a different issue, because I would in certain settings, yes.